Yes, it's hard for you guys to see with the lights on.
I can turn them off right now.
Okay. I'm going to briefly talk about histology of bone real quick because Mr. Wire, you guys probably gone through it already. So I'll briefly talk about this, show you some cases, and if you got any questions in the middle of my talk, feel free to ask. Bones, there's two types of bone. Lamellar bone, it's just normal bone, and a woven bone. Woven bone is usually seen in mature bone and pathological bone. Example, osteoporotic bones. When people get older, their bone gets softer, they don't have a lot of calcium. In ladies, it tends to have osteoporosis because of the estrogen. They go into menopause and their bone gets soft, and you can see them slowly hunching down because the spine, the vertebral body spine, the marrow and bone gets soft and it starts shrinking. You get hunchback. And lamellar bone is normal bone as consists of two parts, the cortical compact bone and cancellous. Let me use this example. The cortical is the outside lining of bone. That is the strength of your bone. Cancellous, cancellous or bone marrow is inside. And it started with cartilage. And the thing about it is, the first thing that goes in osteoporotic bone is the marrow, then the outside cortex gets real thin. So when you see soft bone, the cortex, you can see right here, the cortex is paper thin, and that's easy to get fractured. Several types of cells, you already know probably, going through the anatomy. Osteoblasts synthesize the bone, osteocytes maintains the bone, osteoclast resorbs bone. In the bone physiology, there's always turning over of bones. As you get older, you have an injury, bone keeps resorbing itself and building back up. It's a continuous process. Just think of the osteoclasts are the demolition people in construction, and the osteoblasts are the construction workers. So they keep demolishing the building, and the construction keeps building it up, so forth. And the osteocytes, you can look at them as the foreman, directing what to do. These three cells are very important for your bone health and growth. Osteoprogenitor cells is within the marrow, and these originates, that's where you get all your lymphocytes, eosinophils, white blood cells, red blood cells. It's very important. And the lining of the cells right here, it's makes osteoblasts and osteocytes. The lining inside the bone is called endosteum. The lining outside the bone is periosteum. And that's very important, especially when you do surgery. You got to keep those lining repaired so the bone will have nutrients. Bone marrow, in a young kid, it's filled in the cavity, and it's hemopoietic cells. Again, they produce all kinds of cells, eosinophils, neutrophils, megakaryocytes, white blood cells, red blood cells. Yellow marrow is this what you call the yellow marrow. It's pretty much no longer produces bone at all, and this is a bad place to get bone graft. So when patients have like a leukemia, they need a bone transplant. They don't get it from the legs. They don't get the legs at all. They get it from the sternum, the flat bones, because they still produce bones, bone cells there. And if you haven't seen somebody taking a bone marrow samples from the sternum, that is very painful. Sticking, I think, 14-gauge needle, puncturing the sternum and suck the blood out. Oh, that's enough to wake the dead up. It's very painful. In the marrow, this is a very good in long bones. In emergency, in the long bones, when somebody gets in an accident and they don't have veins to put an IV to get fluid, what they do is they get a big bore needle and puncture it through the cortex into the bone, and they start pumping fluid in there because you have blood vessels that goes inside the bone, and that's what they get the fluid out. So I don't know if you've seen some ER shows on TV when they have a tough time getting a IV line. You see a person sticking a big needle down to the bone, especially in the shaft. Okay, and bone grafts. The marrow is used for bone grafts, so cadaver bone, they harvest this, they clean it up, and And when I need bone graft in my surgery cases, I call them croutons because they look like croutons in salads. If you look at it, you don't want to gross it out, but that's what they look like. And I have a sample picture here later. Bone marrow, source for stem cells, hematopoietic cells, and you can see all kinds of cells that comes out of there. It's very important. And it's bone marrow transplant, stem cells research. That's where to get all the samples there. And the stem cell research, there's a lot of things out there right now. I think it's a sham because it's all cash. Insurance doesn't cover it, and there's a reason why insurance cover it. There's a lot of research still needs to be done, and just be careful. And again, since the bone marrow here is a site for cancer, you get a lot of metastasis, like breast cancer, it goes to the bone. You get liver cancer, it goes to the bone. A lot of cancers go to the bone. Reason being is because there's a lot of blood supply that goes to the bone, because you got cells making inside the marrow that goes out, and you got nutrients coming in. So it's a freeway that goes in there. And you'll see an x-ray later on. Early bone development, when you get an x-ray of a young infant, you get an x-ray in the head, you don't see anything at all, pretty much. Maybe you see a sliver of little white speck, because everything starts with a cartilaginous bone structure. It doesn't show up on x-ray. Then as the child develops, you got calcium being laid down, so you see outlines of the bone on the side, but you don't see the middle. Then when time goes on, blood vessel starts going into the primary ossification center. Then with time, these are the epiphysis. Epiphysis, this is where, then you have a growth plate here, that's where your bone grows in lengthways. And blood vessels starts going into the epiphysis. And that's become a secondary ossification center. And as it grows, you got more compact bone there, more vessels going in there, and this is a growth plate that grows. And as an adult, there's no more ossification in adult already. It's all marrow, and the only area is in the center part. That's why in young kids, they get septic joints without no reason at all. They get sick, they got bacteria floating around their body, and it goes to their joints, especially in the hip, because the blood vessels goes into the hip. In adults, you don't have that anymore. So when a young kid is crying, hurting, and their hips are like this position, this is a nice position where the tension is less. You always suspect an infection in the joints. In adults, in order to get joint infection, you either have to have a cut or you're immunocompromised, HIV, you're on cancer drugs. You don't have a body immune system to fight off any infection. That's how you can get instantaneous infection. And this is the growth plate. Epiphysis right here, metaphysis right here. So if you take this growth plate and draw a line right here, that's what it looks like. When you have a growth plate in an injury in young folks, it always breaks through a growth plate before it breaks through the cortex. That's the softest part of the bone, right here. And when I always say, a young kid playing football, I think he injured his ligament, and it's a 10-year-old. Ligaments don't break in young kids. They're real tough. The first thing that breaks is through the growth plate. So always suspect an injury through the growth plate. Unfortunately, when you get an x-ray, the growth plate is a dark line. Growth plate is a dark line, and when you press on the growth plate, if they hurt clinically, always suspect there is a growth plate injury until proven otherwise. Because a fracture, you'll see later, a fracture through the cortex here, you see a line. But the growth plate is a line. When there's a fracture through it, you can't see any. Again, epiphysis, metaphysis here, in the shaft, and in adult, it closes up. Here's an example. A mid-teen, see the growth plate here, epiphysis, metacarpal head, and look at this, ossification center. Secondary ossification center is not shown there because it's not calcified, it's cartilage. But if you get an MRI that shows soft tissue, you will see metacarpal heads there. And look at this, you can see all the bones. The wrist bones are there. It's just not ossified. yet. Okay, determining height. People always ask me, how tall am I going to be? In the past, they look at scale. There's two things. There's skeletal age and chronological age. Skeletal age, there's a big book out there where they took pictures in a series. I took an average. Okay, a 14-year-old hand looks like this. There's different stages of ossification. Then a 15-year-old looks like this. So what you do is, to determine growth, let's say a person is 17 years old, they want to know how much more growth that person has. So they look at the book. They take an X-ray of that 17-year-old and compare it to the X-ray in the book. So he may be 17, but his skeletal X-ray may show that he's 15, meaning that he may have some growth. Another person may be 14 years old and say, okay, how much growth do I have? You take an X-ray of their hands, they don't have much of a growth plate already, and compare it, his hand X-ray is equivalent to an 18-year-old. They said, you don't have much growth yet. So there's a difference between chronological age and skeletal age. In order to be accurate, you look at the skeletal age. Because when people weightlifting, taking steroids, things like that, the growth plate closes prematurely. So you may be 14 years, that's why you see, how many of you guys see on TV bodybuilders? How tall do you think they are?
Pretty short.
They're not 6 foot. They're yay high. They're not very tall. Because they start stressing their muscle and body, and it closes prematurely. And some take steroids, obviously, closes the growth plate. Okay, this is an estimate here. You add the height of each of your parents. Divide by 2, that's your average parent's height. And for girls, minus 2 inches from that, that's from the average parental height, so that can give you an idea how tall you're going to be. For boys, add 3 inches. Any questions on this formula? It's very simple. So you can go home and ask your folks, how tall are you, how tall you do the calculation, and add, if you guys add 3 inches from the average height, and ladies at minus 2, and see if that, and ask yourself how tall you are and see if you fit in that pattern. Rapid growth takes place in the first 2 years. First year, the baby grows an average of 10 inches. 10 inches first year. Second year, it goes down to 5 inches. And from second year to puberty, average 2 to 2.5 inches. Puberty growth accelerates again, 8 to 11 years in girls and 10 to 13 years in boys. That's a growth spurt. That's your secondary growth spurt. So when your voice change and when womanhood starts in ladies, you got approximately an average of 2 years of growth left. So if your voice hasn't changed, you can keep on growing. Growth slows down at age of puberty, and then stops. Age 15, and girls, boys 17. That's why they say girls are more advanced than guys. They get to adulthood quicker than we guys do. Bone healing, I think Mr. Weider's gone through bone healing already. There's pretty much 6 stages. There's an impact and injury. Then you get the induction, where you get inflammation, hematoma, inflammatory cells. Then the next phase is continued inflammation. The most important for bone healing is a periosteum outside the bone. If that's not disrupted, you get healing real quick. Like in kids, the periosteum is real thick. In adults, it's very thin. That's why when you see the bone heals in young kids, you see a big blob of bone on the side. And you get the soft callus, and then you get ossification, where the soft callus convert to ossification. That's where the osteoblast and osteoclast comes in, start remodeling the tissue. And it continues to remodel when you lay down lamellar bone. And these are example inflammation, soft callus, hard callus, and remodeling. And here's another thing. Adult bone healing, 8 to 10 weeks. Young kids come and see me playing football. Parents will say, when can Johnny go back to playing football? I tell them, well, bone heals in 8 to 10 weeks. And I asked him what position they play. If they're a receiver, I said, you're kind of done because you need to catch the ball. And I told him, well, if you're a kicker, you can play, just kick the ball and run straight to the sideline so you don't get hit. That's the thing, we gotta watch where the stages are in their healing. And in children, 6 weeks. Kids less than 5 years old, 2 or 3 years old, oh my gosh, in 2 or 3 weeks, there's a lot of bone healing. They're pretty much close to healed. It's impressive. I wish we still have that healing process in the adult, but we don't. Things that affects healing. Your age, the older you are, unfortunately, the slower you heal. Nutrition, you don't eat healthy, you don't heal very well. Vitamin deficiency, vitamin D deficiency. You can get rickets or any absorption problem in your stomach for vitamin D. You don't get that. Immune status, if you're immunocompromised, you don't heal very well. Other diseases that can affect as well. Infection is very important in blood supply and healing. Open fractures, when the bone sticks out of the skin, they don't heal as well when there's a closed fracture, when the bone doesn't stick out of the skin. Blood supply is very important. Bone needs blood supply to get nutrients in there to heal. So when you smoke, bone healing, it will not heal as quick. A lot of surgeons out there will not operate on a patient if they are a chain smoker because it will not heal. And the foreign body there will continue to cause inflammation and cause an irritation where your cells goes in there and attack the normal cells. That's why it won't heal. Okay. This is an example of healing a femur fracture in a 2-year-old. Got apposition and remodeling. And here's one, the periosteum. This is the outline of the periosteum. As it heals, you see more bone laying down. And with time, this smooths out. In primary fixation, overinduction to fixation, where you put the bones together where it's supposed to be, you don't see callus formation. They consider it as primary healing. This is called secondary healing, when you see callus. Primary healing is just, it heals and you don't see any outside bone. This is secondary healing, because the rod that comes down here, it did not make the fracture fits like a puzzle. That's why you got secondary healing callus there. And if you understand these basic concepts in healing, bone cells and everything, and you can say yourself, you nailed it. How would you think we take this out? Okay. Have you guys gone through skin? Have you talked about skin already?
We did skin, yeah.
Okay. You know there's normal flora in the skin bacteria, right?
Yeah.
Okay. In order to take this out, you got to cut this first. You got to cut this first, okay? Cut this first. You got to cut this here, because anything that's outside the skin, you pull it through the skin, you're just introducing bacteria inside, and it's going to pass out. Okay, let's go through a few cases here real quick. This is a golfer who came to me and said he's snapping the button, and he felt a pop in his thumb and it hurt. It's an enchondroma. It's a benign cartilaginous tumor. What happens is, remember in bone, it starts with cartilage, and the cartilage converts to bone. Somehow the process did not continue here. It stopped at cartilage stage. So you got the thin bone lining here, and it's real thin, and he snapped it. And it's what we call a pathological fracture. It's woven bone in here. So what we do is, we took some bone graft, croutons. These are volunteer cadaver graft from marrow. Croutons, so what we do is we take some of this and crunch it up, draw some of this blood and put some blood in here and pack it in to the marrow. And your body, the osteoclast and the osteoblast will start remodeling that and start kicking in and stimulating bone growth again. Here's a young 15-year-old that fell, a fracture of his ulna. This is what we treated closed, meaning that we put him in a splint, or if we needed to reduce it, we reduce it from the splint. We don't do any hardware, let it heal. And with time, secondary growth, healed. It's healing. This is a clavicle fracture. It's out. And if you know anatomy, a shorter girl, this probably won't reduce. If the bones are not touching each other, studies have shown that if it's more than 5 millimeter, it's too far for the bone cells to jump to the other side. The bone has to be in contact. So if there's any contact, the bone can heal. But there's no contact, there's tissue in between these two bones. So you can leave this for 50 years and it ain't gonna heal.
So how do you reduce that?
So how it happened?
Reduce this, you can't, this one, the best way to reduce it, sometimes you put in figure eight. Figure eight, you stretch their shoulder out. Retract the shoulder. Retract the shoulder, so hopefully you pull this out with figure eight, strap, and push this down. But sometimes with a sharp edge there, part of the scalenus muscle there, it's trapped inside the muscle, and that's what we found out when we went in there. Went in there, put plates and screws, and by putting the fractures together, it heals primarily, so you don't see a lot of callus. And this is the tools. I love orthopedics. We got the best tools in the operating room, plates and screws. You can't go to Lowe's or Home Depot and get those because they will rust. These are stainless steel. We always consider ourselves as not doctors, but sterile carpenters, because we deal with drills, hammers, seriously, mallet and everything. This is a person who we advise not to play basketball until it's done healing. So he played basketball and he re-broke where we fixed his bones. So listen to your doctor when they say, don't play yet. So he bought himself a second surgery, went in and took out the screws. These are plates and screws, there's our drill, plates and screws. It's called open reduction to fixation. This is an example of how blood supply is very important to the bone. There's a condition out there, it's called Kienbock's disease by Dr. Kienbock's. This is MRI. When you have good bone, it lights up. When the bone's dying, it becomes black. And you can see here and here, you can see more here. This bone is called Kienbock's because it needs blood supply. If it doesn't have blood supply, it starts dying. And that's what happens to all parts of your bone. Scaphoid right here, if it doesn't have blood supply, it will die as well. It's called Preiser's disease. So this is a little advanced. I'll tell you how we treat this. If it's dying, we either do a fusion or take the bone out and let the bone drop so you can maintain motion. This is a little advanced. Here's one. It's very important. Studying anatomy, what the anatomy should look like normally. Because if you know what the anatomy looks like normally, you can tell when the bone is not in the right position. This is a wrist bone. Wrist bone, let me go back here. Okay, you see how this wrist bone here, everything's lined up? There's spaces between the wrist bones. Patient fell, injured it. What do you see? Bones overlapping. Bones overlapping. If you took a lateral x-ray, it's dislocated from the lunate. You can see that. Took that picture, drew it out. This should be over here. So if there's any bone overlap in the wrist, be very suspicious that something has happened. Believe it or not, it's been missed by a lot of ER physicians. And that requires open reduction to fixation, meaning that we open it up, reduce the bone, and I use anchors here to repair the ligaments. And that's what it's supposed to look like. See the spaces? It's what we call Galula's line by Dr. Galula in Washington University. Did research on the Galula's line. You follow those lines compared to, look at this x-ray here, and see, it overlaps. Here's a case. This is a guy with a gunshot wound in his left hand. Believe it or not, he teaches gun safety. He's cleaned his gun. He accidentally shot himself.
Okay. Why was it loaded? It wasn't loaded.
Yep. Gun safety. He was very embarrassed when he came to saw me. So what we did was, his tissue was blown off. We had to make sure the tissue heals up. I put pins in there to let it heal. Because of the impact of the explosion, the soft tissue there was not very good. Need time for blood supply. Unfortunately, blood supply did not reconstitute in this area. And the blood supply in the shaft of the metacarpals are very tenuous. It's called watershed. You know what watershed means? Watershed is, it's by diffusion. Most of the blood supply comes here and come here, and there's no direct blood supply here. It just diffuses in this area, so you get indirect blood flow. Tried to let it heal, it did not heal. So we went in there, no healing, callus formation. This is a problem. He smokes too. So we did, that's the area, the defect right here. This is his good bone, and good bone right here, that's a defect. We cleared it out, so there is a defect there. So we took a cadaver bone, a fibula, measured it. It's all by eye, there's no rulers and stuff. You just rule it and eye it how it looks. So doing surgery like this, reconstruction, you gotta have a little art. Try to figure out, know your three dimensions. So I cut up a piece like this. I fashioned it in there. Put plates and screws. And this is before. Put plates and screws there. And this is some BMP bone, bone morphogenic protein. It has there's two types of bone graft. One is osteoconductive. Osteoconductive is your croutons. Conductive means that you have a skeletal structure where the cells goes in and fills up that space. Or osteoinductive. Osteoinductive is stimulants to stimulate bone, chemical. And these are stimulants. So I put it in there with plates and screws. And let the pins there for a little bit, then later on pull the pins out. And this picture was about 3 or 4 years ago. He has full function in his fingers. He's out there teaching gun safety. And I told him I don't want to see him back in the clinic if he blows up his hand. Okay, here's one. Okay. Car accident, hand outside, roll over. Unfortunately, rolled over to his hand and took off a lot of soft tissue. It looks worse than it is. What happens, there's a tendon torn here, open wound. His bones, his carpal bones are everywhere. I mean, you take this out, drop it there, you take this out, you drop it there, you take this out. I mean, it's not in the same spot. Yeah, ligaments are torn. Look at this x-rays. It doesn't look right, does it?
Nope.
Bones are everywhere. This is a good puzzle that night to fix. So I'd like to say, anatomy is very important. You know the anatomy, you know what the bone looks like, you know where the bone needs to be, and you can put it together. Got it together, we fixed up, fixed the tendons. He's got his hand, good tendon. From here to here. Look at all that. Any questions? Yes?
You did that surgery?
Yes, my partner and I did it. It usually happens in the middle of the night. Yes, it always affects our sleep.
How long would something like that one take?
Well, the problem is if you and your partner are working together, there's two brains functioning, and sometimes the two brains does not function cohesively. So you tend to kind of
It's like being married.
Let's do this. No, let's do this. Let's do this. I think it should be because both of us want to do our one thing. This took about, I would say, 3 hours. 3 hours, but either one of us doing it, it'll take us about an hour and a half or something because we know what we want to do. Then unfortunately, listen to each other, tag team. Any other question about injury, open reduction to fixations? Yes?
Is it true that bones grow back stronger than?
I'm sorry?
Or do bones come back stronger how they
Yes.
were before you?
Yes, once the bone is healed, it's stronger than it was before. The only time it does not come back as strong is if the bone does not completely heal and there's scar tissue there. That's when it's still weak.
There's that one X-ray. It's like I think you said it was a little kid and like the femur bone. How come you didn't like? How come it wasn't put back together or like
Your femur?
back line?
Let's
It's like
see.
before that nail.
This one, yeah.
How come
This
you
one.
didn't like realign it? How come you-
Don't need to because kids will heal. What we did was we put web roll, it's those cotton roll. Who's taken sports medicine with Mr. Hamlin? You know those white cotton roll? Yeah, web roll. We just wrapped it up because it will remodel. In adults, in kids, it will remodel. In adults, we have to put together because we don't remodel anymore. Like a broken wrist here, their wrist can be like this, bent down 45 degrees. Don't treat it. Bring the kid back in a year, it's straight. So we like to do that. We tend to do that in about, if you look close to 10 years old, we tend to fix it straight because it's 50-50 how it's going to remodel. I don't want mom to come in. The key is when a kid comes in with an injury, it's crooked, I just say, let's try to get as best straight as possible, knowing I know it will remodel. It's just one of those things. You think it's going to happen. Remodel, it didn't happen. Then when you get parents coming in, I thought you said it's going to be straight. Then we end up re-breaking the bone, cutting, re-breaking the bone, and straightening it out and put plates and screw. So in the beginning, when there is a fracture, it's malaligned, I tell them if you want it straight, it's best to take care of it now. Yes.
How would you re-break the bone?
I'm sorry?
How would you re-break the
Bone with a saw. We got an oscillating saw. Unfortunately, when you re-break the bone, it's not only a two-plane, it has to be a three-plane. Three-plane because it's a three-dimensional structure. You have to make sure you have to have a spatial view of what the bone looks like this, okay? Let's say the bone is crooked this way, okay? Not only you got to correct it in this plane, right to left, you got to correct the plane forward and backward, and you got to correct the plane turning, okay? So you get 3 planes, anterior, posterior, lateral, medial, and rotation. And that's a little, I mean, it's not a simple saw cut. You gotta make a saw cut here, you gotta make a saw cut there, then you gotta make a saw cut differently, and you rotate it and put plates and screw it. The problem with that is sometimes what we call an osteotomy site, that's where you re-break the bone, it does not heal properly. Any other questions?
Yeah.
Yes.
So how many times will a bone like heal itself together?
I'm sorry?
How many times will a bone like heal itself back together?
It will heal.
Like
It will heal.
endlessly?
The question, as long as the bone is in contact with each other, it would heal. I tell families and patients this, the bone will heal. The question is, do you want the bone to heal properly or do you want the bone to heal crooked? And if you look at anatomy, anytime there's a bone crooked here, it affects this joint, it affects that joint. If this bone healed crookedly, it affects this joint, it affects that joint. Everything's tied together with ligaments. The only time they will not heal properly if they smoke, or they're not compliant. You put them in a splint, you say you got to rest it, don't move it, but they keep using their hands. It's like gluing 2 things together. If you don't let the glue set, holding the piece together, it will not set. If you keep moving it, it's not going to set. And another thing that won't heal properly is called a cancer, pathological fracture. You have a cyst there.
So when you do cadaver, when you do grafts from a cadaver, you have to worry about rejection like you do a normal organ?
No, they go through process. They clean this up pretty well. They're very, very stringent FDA regulation. So they'll go through processes of cleaning it to make it, the antigens to make it gone. It's sterile.
What if I break like my skull? How do you fix that?
First of all, I'll be referring you to a neurosurgeon. I don't do skull. Skull is the hardest bone in your body. So it's going to take a lot of energy or tremendous injury to break your skull. Like a real bad accident. When you break your skull, have you talked about brain already?
No, that's next semester.
You come to coup and contra coup. That's a coup contra coup. You're smiling here. Do you know what that is?
No.
What happened is, since the bone here, the skull is very hard, coup contra coup, that means you get hit here. Since this does not absorb the energy to shatter, it transferred the energy to the back of your brain. That's when people get hit in the front real hard, they got hindbrain injury. It's called coup and contra coup. And that's why when people get in a fight, when you get in a fight, you're going to punch somebody. Where are you going to punch them?
The jaw.
Face, right? And what happens? You're going to hit them in the face. What did the other guy do? Duck, right? And you miss their face and you hit their head. And you break your hand. Their skull's still intact. But if the skull cracks, the first thing you got to worry about is the brain itself, not the skull itself. Because if the skull cracks, the brain will swell up, and in fact, you want the skull to crack, because when it swells up, at least you have pressures to be relieved. But if it doesn't relieve, your brain will die. And fixing the skull is very simple. Just small plates and screws. It's like a puzzle. Put it in there, drill a hole, small plates and screws to put it together. That's why when we do a craniotomy, tumor in the brain, they make an incision here, peel your skin all the way down here, and peel it up, and take a drill. They use a drill to make perforation, and they pop it open. Huh? So, if you're going to punch them, do an uppercut, you'll miss their head. But if you do an uppercut, you'll get their face, because they'll bend down and you hit them in the face. I'm not teaching you how to fight, but you didn't hear that from me.
What's that? No.
You're taking notes.
I don't have to take notes anymore. All right, there. Let's say that break didn't require an open reduction. You know, I have a daughter. She could probably break her wrist. I don't know. She's pretty much a daredevil. What would be a normal closed reduction procedure? How do you realign it? Is there the harness they put them in, or is...
No, extra-articular fracture. Extra-articular fracture, that means outside the joint. Breaks right here. What we do is, first of all, you got the patient relax. I put him in finger traps. Put him in finger traps, let him relax, and set the bone. You get a sugar tone splint, I set the bone, and put them together. Now, let's say the fracture's reduced real nicely. I followed them up on a weekly basis for 3 weeks, because even though the bone is well reduced, it can still shift. In adults, if we're going to do something, I try to do it as close to anatomical as possible. Short of closed reduction, a little more than closed reduction is called closed reduction percutaneous pinning, meaning that you can still set the bone without making a cut, but you can put pins in there. You can fire pins in there to hold it in place. That's a closed reduction percutaneous pinning. Then if that doesn't work, the next option is you make a big cut right here and put plates and screws. So treatment of fracture, closed reduction percutaneous pinning, and open reduction to fixation. Open reduction to fixation meaning that you actually make a cut in the skin and literally put the bones together. That's open reduction. You mentioned earlier they have a tough time remembering the wrist bones.
I don't ever teach them the wrist bones because they'll always forget them. But
There's an acronym.
yeah.
There's an acronym, wrist bones. There's 8 wrist bones. Scaphoid, lunate, triquetrum, hamate, capitate, trapezoid, trapezium. Trapezoid, trapezium is hard to remember because around the thumb. Just think about if you're in a trapeze, you're holding with your thumb. Right below the thumb is the trapezium. Right next to it is a trapezoid. So acronyms I learned is scared, lovers, try, position, pisiform, that they cannot handle. You want to go through that again? Scared, scaphoid, lovers, lunate, try, trapezium, position, pisiform, that, trapezium, they, trapezoid, cannot, capitate, handle, MA.
I think that should be an extra credit question.
It's on a house episode that we watched second semester. There, he's teaching
And just a lot of acronyms.
Yeah.
And another thing, nomenclature. Know the nomenclature like for the hand real quick. For the hand. Orthopedics likes to categorize things. The thing that tells me, okay, let me ask you a question. How many fingers in the hand? Anybody? Is it 4 fingers or 5 fingers in the hand? It's 4 fingers and a thumb. Reason being is because the thumb does not have a middle phalanx. Each finger has a distal, middle, proximal phalanx. The thumb only has a distal and proximal phalanx. That's why when they say middle finger, you got 4 fingers. Which one's the middle finger?
Those two.
We don't have one. If you consider the middle finger as this finger, that doesn't mean you're saying that the hand has 5 fingers, which the hand does not have 5 fingers. I argue with that with my partner all the time. Okay. So the best way to describe it would be thumb, index, long finger, ring finger, small finger, or little finger. So when I teach the residents in the emergency room and they tell me about the hand, sometimes they say P1, P2, P3, P2, P3, P4, P5. I don't like that because it doesn't tell me anything. More descriptive. Okay, if they tell me, let me tell you, okay, a person came in with a long finger, proximal phalanx fracture. You have a picture where that fracture is located? Right here. Okay. Okay. If somebody tells you it's a 3rd digit P3 fracture, do you know what that is? It doesn't tell you anything. Because some people consider this a 1st digit. Some people consider this is a 1st digit. Okay? So you're going, okay. Then some people consider this P1 as distal, P2 as middle, P3 as proximal. Some people flip that over. It's P1, P2, P3. That's why it's best to describe it long finger, proximal phalanx fracture. When they say that to me, I know exactly where it is. Or long finger, metacarpal fracture, right here. Index finger, distal phalanx fracture. It's right here.